Hello there, my name is Ashley Poulin, and I have done my case study on migraine headaches. My patient is Fred Baker. He is a 44-year-old male patient. He is married with 3 kids, a social worker. 4 months ago, he moved from North Carolina for work. He is a smoker, does not use any illicit drugs or ETOH. He has no known allergies. His past medical history includes hypertension and migraines. He does have a positive family history for migraines in his mom, dad, and his sister. His current medication list includes Imitrex, 50 milligrams PRN daily for migraine, diltiazem CD, 120 milligrams daily for migraine, and hydrochlorothiazide. His history of present illness, chief complaint is increasing frequency of migraine headaches. It's been gradually increasing in frequency over the last 4 months. Prior to this presentation, he had approximately 1 migraine per month. They would last 2 days and were responsive to Imitrex. In the last 4 months, he's had 2 to 4 migraines per month. He correlates them with increased workplace stress, increased smoking, poor diet, less exercise. They feel the same as his past migraines, but have been more frequent and severe. He describes the headache as unilateral, normally right-sided, constant, throbbing, and moderate to sometimes severe in intensity. On a scale of 0 to 10, he has rated them a 5 to a 9. He has associated photophobia and phonophobia and occasional nausea. He reports no auras. They last approximately 4 days and have caused him to miss work on 3 separate occasions. He has taken Imitrex for acute therapy as needed. In the past, it has been effective, but he's taken it greater than 10 days this past month, and it seems to not be working anymore. He was also started on diltiazem for preventative maintenance of migraines 3 months ago by another provider. He is here establishing care with my practice and seeking help for migraine management. His vital signs are as followed: 82 for a heart rate, 132 over 79, 99% on room air, 16 and 37 degrees. He is currently pain-free, and his last migraine was last week. He is alert and oriented. All cranial nerves are grossly intact. Review of systems was unremarkable. He has no records of laboratory testing or diagnostic imaging. A bit about the pathophysiology of migraines. The once common conception that the headache associated with migraine was caused by vasodilation and the aura of migraine is caused by vasoconstriction is no longer considered viable. According to UpToDate, the leading theory is linked to a phenomenon known as cortical spreading depression. It is a self-propagating wave of neuronal and glial depolarization that spreads across the cerebral cortex. It is hypothesized to cause the aura of migraine, activate trigeminal nerve afferents, and alter blood-brain barrier permeability. Essentially, what happens is the cortical spreading depression occurs, which means the individual has this wave of neuronal and glial depolarization that spreads across the cerebral cortex and causes the aura often associated with migraines. This activates the trigeminal nerve afferents that innervate large cerebral vessels, pial vessels, dura mater, and the large venous sinuses. The trigeminal ganglion is also stimulated in the process, which results in the release of substance P, calcitonin gene-related peptide that does cause vasodilation, and neurokinin A, which causes neurogenic inflammation that prolongs and intensifies pain and also causes sensitization of meninges. That all combines to cause not only the migraine, but also the increased stimuli to painful and non-noxious stimuli. Elevated levels of these neuropeptides have been found in the CSF of patients suffering from chronic migraines, suggesting chronic activation of the system in these patients. It is thought that in patients that do not experience an aura, the depolarization associated with cortical spreading depression is occurring in areas of the brain where consciousness is not perceived, such as the cerebellum. Activation of serotonin receptors is known to be important in the acute treatment of migraines, but its role in the pathophysiology is unclear. There are four main stages of migraine headaches that have generalized features that are listed here. The first one is the migraine prodrome, which 60% of people experience. This includes symptoms such as euphoria, depression, irritability, food cravings, constipation, neck stiffness, and increased yawning. It generally occurs 24 to 48 hours prior to onset of migraine. The second is the migraine aura. This is experienced by approximately 25% of people. They can have one or more focal neurological symptoms, generally before the onset of a headache. Typically, they have a gradual onset, last no longer than 1 hour, and are completely reversible. They are often categorized by positive features such as visualizing bright lines, shapes, and objects, or hearing ringing noises or music. They may feel burning, pain, or paresthesias, or experience jerking or repetitive rhythmic movements. Some negative features include loss of vision, hearing, feeling, or ability to move a part of the body. Less common, people can experience language auras. You can see why some of the symptoms can often be confused with those of a TIA. The third is the migraine itself. It is often but not always unilateral, and they tend to have a throbbing pulsatile quality. They can be associated with nausea, vomiting, photophobia, or phonophobia. And fourth is the postdrome, which often leaves people feeling exhausted, and sudden movements of their head can cause pain where the headache once was. Some precipitating and exacerbating factors include emotional stress. This occurs in about 80% of people. Hormones in women or menstruation, 65% of people. Not eating, 57% of people. Weather, 53%. Sleep disturbances in 50%. Odors in 44%. Neck pain in 38%. Lights in 38%. Alcohol in 38%. Smoke exposure in 36%. Sleeping late in 32%. Heat in 30%, certain foods in 27%. These often include nitrates, wine, aspartame, MSG, chocolate, and tyramine. Exercise as well in 22%, and sexual activity in 5%. Next up is the diagnosis of migraine. You want to be sure that a migraine is actually what you're dealing with, of course, before you begin treatment. There are a number of different other kinds of headaches that it could actually be, and a number of things that could be on your differential. So just be considering this. ICD-3 criteria for migraines without aura includes at least 5 attacks fulfilling the following criteria of B through D. A headache that lasts 4 to 72 hours, untreated or unsuccessfully treated. The headache has at least 2 of the following characteristics: unilateral location, a pulsating quality, moderate or severe pain intensity, aggravation by or causing avoidance of routine physical activity. During the headache, at least one of the following occurs: nausea, vomiting, or both, photophobia, and phonophobia. And it's not better explained by other ICD-3 diagnoses. For sake of simplicity, I won't get into criteria for diagnosis of migraine with aura, as this is not what Fred is experiencing. There are no laboratory tests to diagnose migraines. Neuroimaging is not necessary in most patients. Some clinical situations that may warrant neuroimaging is the first or worst headache, recent significant changes in the pattern, frequency, or severity, new or unexplained neurosymptoms, headache always on the same side, headache not responding to treatment, new onset of headache after age 50, new onset of headache in patients with cancer or HIV, or associated symptoms such as fever, stiff neck, papilledema, cognitive impairment, or personality changes. The overall goal of therapy is to minimize the impact of the migraine on the patient's quality of life, social functioning, and ability to work. prevention of migraine by avoiding identified triggers, often identified by the patient maintaining a headache diary, and prophylaxis for frequent migraine sufferers, and minimizing adverse effects of pharmacotherapy and avoidance of medication overuse headaches. Oftentimes, patients' migraines are not going to be completely cured, but it's just finding a way to manage them so that they can have all of those things that I just mentioned. Pharmacological management is divided into two major components: acute or abortive therapy and preventative or prophylactic therapy. There are no strict definitions that prompt preventative therapy, but general indications include frequent long-lasting headaches, greater than 4 per month, or headache greater than 12 hours, significant disability or diminished quality of life despite acute treatment, contraindications to acute therapy, failure of acute therapy, serious adverse effects to acute therapy, risk of medication overuse headache, and menstrual migraine. Because Fred meets criteria for numbers 1, 2, 4, and possibly even 6 that's listed there, and is currently on a suboptimal preventative medication, I'm going to focus on adjusting his preventative regime. So just to reiterate, Fred is a 44-year-old male patient with hypertension and migraines. He has a lot of increased stressors, and his headaches have been getting worse and keeping him home from work. He has tried propranolol and timolol preventative therapy in the past and failed secondary to fatigue, lethargy, and depression. His previous provider then changed him over to diltiazem CD, 120 milligrams daily, with Imitrex, 50 milligrams as needed for abortive therapy. Imitrex has worked in the past, but his use has significantly increased, and he is no longer finding the relief he needs to get along with life. First-line recommendations for preventative migraine management, according to the American Academy of Neurology and up-to-date, are amitriptyline, divalproex sodium, and propranolol or timolol. Calcium channel blockers are used, but they actually have lower efficacy, limited strength of evidence, and mild to moderate side effects. If calcium channel blockers are used, verapamil is recommended over diltiazem. Diltiazem actually has no scientific evidence of efficacy, and because of that, it's recommended that it should not actually be used for migraine preventative therapy, especially in the setting of a number of other better options. So because of this, I have chosen to discontinue his diltiazem and prescribe amitriptyline 10 milligrams PO QHS. Since Imitrex has worked for him in the past, he should continue taking 50 milligrams PO as needed. He may repeat the dose times 1 2 hours after his first dose to a max 200 milligrams per 24 hours. Hopefully, the combination of amitriptyline and therapeutic lifestyle changes will decrease his need for Imitrex that could be contributing to medication overuse headaches. So, amitriptyline. It is a tricyclic antidepressant. It's the only TCA that has been proven effective for migraines. Its use for migraines is still actually off-label. The mechanism of action is that it increases the synaptic concentration of serotonin and or norepinephrine in the CNS by inhibition of their reuptake by the presynaptic neuronal membrane pump. As mentioned previously, serotonin's role in the pathophysiology of migraines is unclear. It's thought that excitatory serotonin receptors, specifically 5-HT2, when activated, can lead to migraine. There are theories that hypothesize serotonin has a direct impact on cranial vasculature, that it plays a role in central pain control pathways, and that low serotonin states may result in a deficit in the serotonin descending pain inhibitory system that activates the trigeminal vascular nociceptive pathways associated with cortical spreading depression that we talked about earlier. A bit about the pharmacokinetics of amitriptyline. Its onset of action may vary in each individual. However, 8 to 12 weeks of treatment are generally required for an adequate migraine prophylaxis trial. It is rapidly and well absorbed. It is also rapidly metabolized, mostly by the hepatic system. It is excreted primarily in the urine, but also in the feces. Its half-life is 13 to 36 hours, and its time to peak serum is 2 to 5 hours. It is a substrate of those cytochrome P450 enzymes listed there. The ones that I've starred are major, and all others are considered minor substrates for the drug. And then it is an inhibitor of those cytochrome P450 enzymes labeled there, all weekly. Fred takes hydrochlorothiazide, Imitrex, and denies additional OTCs or herbals, and has no known renal or hepatic disorders. So there are no issues here with him taking amitriptyline with the medicine that he is currently on. Just be sure to cross-check your patient's drugs when prescribing amitriptyline, because it does have a long list of different medications that it can affect. Therapy for migraine headaches using amitriptyline is often achieved at lower doses than what is required for treatment of depression. So there actually may be a decreased risk of some of the side effects that are listed here and some of the cautions. Most concerns surround the anticholinergic effects of the drug and the moderate to marked sedation that may accompany it. This is why it's prescribed to be taken in the evening, and tolerance to these effects usually occurs. It's been identified in the Beers criteria as a potentially inappropriate medication to be avoided in patients 65 and older due to its potential for sedation and orthostatic hypotension and potential to cause symptoms of SIADH or hyponatremia. It's contraindicated with hypersensitivity, of course, to any component of the drug. Co-administration within 14 days of MAOIs or cisapride, and in the acute recovery phase following MI. It is black boxed for increasing risk of suicidal thinking and behavior in children, adolescents, and young adults aged 18 to 24 with major depressive disorder. You should use caution if the patient has cardiovascular disease, urinary retention, prostatic hypertrophy, glaucoma with angle closure, if increased ocular pressures, seizure disorders, thyroid disease, diabetes, asthma, Parkinson's disease, hepatic impairment, schizophrenia, bipolar, ECT, ETOH abuse, GI and GU obstruction, or high environmental temp. You should also avoid abrupt withdrawal of the drug. Some of the common side effects are listed there: drowsiness, dizziness, constipation, blurred vision, palpitations, tachycardia, impaired coordination, and the list goes on and on. I won't read them all to you. Obviously, this is not a desirable side effect profile, but he's already failed beta blocker therapy, and his migraines have been so debilitating that Fred really requires a drug with proven high efficacy. The only other drug with proven high efficacy is the divalproex sodium, which has a side effect profile that is comparable, and 4 instead of 1 black box warnings. Hopefully, Fred's migraines can be controlled at a low dose to minimize the risk. And just also to touch on the fact that it's covered by most insurances and is on the target $4 list, whereas the divalproex sodium is not. And lastly, some patient education and a bit of monitoring information for you as his caregiver. Fred should go home and maintain a headache diary to help maximize therapy and help identify and avoid triggers. He should utilize some non-pharmacological measures to prevent and treat migraines, such as relaxation, massage, or ice. He should avoid over-the-counter meds. It is essential to allow adequate time for trial before a change in treatment plan, usually 2 to 3 months. So he should be aware of that and encouraged patience. He should take his meds exactly as prescribed until follow-up and return promptly for any perceived side effects. If the patient does have cardiovascular disease, you should get an EKG and monitor BP and suicide risk and follow-up. And just be aware, as his provider, that modification of this plan may happen multiple times before achieving your goals. Evaluate progress with open dialogue and utilization of the headache diary.